Hi, everybody. I think I recognize some familiar faces. I am Claire Wong. I'm the DSAM's Associate Deputy Director, and I oversee the Bureau of Research Evaluation and Population Health. So super excited to be in the company of people who love data and would love to have using data to make decisions, and that is definitely our goal. Dr. Martins is on my team, and we've been really excited to see the launch of the 988 nationwide. But also, I'll say a little bit about this, that 988 is a national initiative implemented locally. And therefore, I'll tell you a little bit about the history about how we implement 988 in the state of Delaware, because every state and jurisdiction is implementing it in a different way, depending on where they start and where they're heading. In front of you, there are some materials that MJ has kindly printed out there from SAMHSA. Thank you. That gives you a little bit of a background of 988 from the federal standpoint. What I also brought with me today are some promotional materials that DSAM has produced using national, communication materials that include suicide warning signs for adults that you can share with friends, family, loved ones. And I also have some stickers. I've been told that these are very popular. I'm not sure. I don't put stickers on my water bottle, but many people do. And they're the top and down, so there's some there. The wallet cards were requested by our law enforcement and EMS colleagues quite a bit, so that they can hand out to people when people are going through the crisis. So take them, but let me take a few minutes to tell you about 988 implementation in Delaware. So, this doesn't work, but it's interesting. I was in university faculty about more than 10, 11 years, and I started using the transparency things. So I've encountered all kinds of different challenges.
Give it a shot now.
All right, let's do it. Okay, you get it. Yeah, no, I moisturize and I use sunscreen. Okay, so my agenda is telling you three things about 988. One is, what is it and why does it matter? Secondly, how does Delaware implement 988? As I mentioned, this is a national, congressionally legislated initiative, but it's relying on state and city sometimes and tribal nations to implement. The big picture will be at the end, like, why are we doing this, and why 988 is only one spark of the entire crisis continuum. When we really think about 911 started 50 years ago, and really it's the notion that everyone has the right to have access to emergency services. And today we know that behavioral health crisis is not treated as the same. The access to these supports are not the same as if you have a heart attack. Right, so this is the turning point for behavioral health, and we're excited about it. So, in a nutshell, at the highest level, some people might say, why is this such a big deal? We are celebrating 988 as the 1-year anniversary. As you know, that 988 is not brand new. It used to be the National Suicide Prevention Lifeline, which you can dial still today, 1-800-273-TALK. And so in 2022, through a bill in Congress that was passed and signed by President Trump, that the National Suicide Prevention Lifeline is transitioning into an easy to remember 3-digit number, 988. So, and then the branding also changed from suicide NSPL to 988 Suicide and Crisis Lifeline. It does a couple things. One is to make it easy to remember, of course, so it's more accessible. But secondly, it also destigmatizes behavioral health crisis. Unfortunately, this bill in Congress did not come with money. So this is the beginning, not the end. We're receiving some federal funding coming out from SAMHSA in subsequent acts and bills. And of course, I'll tell you more about how Delaware is financing going forward. So this is the timeline. So the entire idea of having a suicide hotline starts in 2001. when Congress appropriated funding for suicide prevention hotline, and NSPL was launched in 2005. In subsequent years, the Veterans Crisis Line went into effect. I think it's a press one to get into the Veterans Crisis Line, and there's chat services being incorporated. But it's only until 2020, there's a National Hotline Designation Act that was signed into law, and 2022 is the soft launch. So the Delaware started to plan for 988 through a planning grant in 2021. And that is when the first meeting of the 988 Planning Coalition that I was fortunate to coordinate started to meet in April 2021. So from the national level, SAMHSA has this 5-year vision. Yes, there's NSPL centers operating nationwide. However, they're not always accessible. In the state of Delaware, we're a little bit lucky. Our NSPL, National Suicide Prevention Lifeline, has been operating for many decades, and everyone in Delaware can call them and reach someone. It might not be the case for the state of Texas, for example. So in 2023, the vision from the national level is to have someone to call. 90% of, can you all see this with this owl being in the way? Okay. 90% of all the 988 contacts can be answered in state. That is the vision there in 2020 by 2023. Right now, we'll get to this a little bit. In Delaware, it's about 75% of the calls placed into 988 is answered by someone in Delaware. The overflow goes into a national backup center. 2025, by 2025, there will be someone to respond if somebody cannot resolve or de-escalate over the phone. Someone needs to go out to someone's house. The SAMHSA's national goal is to have 80% of people nationwide can have access to a mobile crisis team. And this is the third component, is a safe place to go for a small proportion of individuals after talking to someone on the phone and have mobile crisis intervention needs to be admitted to a facility. The goal is to build capacity so that 80% of the individuals nationwide have somewhere to go. So it is not an overnight kind of initiative, and it will take concerted effort between state and federal and municipal to really expand the current capacity. However, this is very timely, and with the upcoming September Suicide Awareness Month, we know that in Delaware, someone dies by suicide every 3 days, and youth suicide ideation and attempts through some of the reports from this group also show that mirroring the national statistics that youth suicidal ideation and attempts escalated during the COVID pandemic. And this struck me a lot when I first heard it. So for every person died of suicide, approximately 316 people would seriously consider it. So there is their impact that may not be seen right away when someone you love, someone in the community, someone is visible in the public media, or sometimes even fictional. As we know, some of the Netflix dramas do have people dying of suicide. People are affected and so on. So, and the last point is also an important one. Nearly a quarter of people killed by police had a known mental health illness. And this is also why this is so important to have a capacity from the behavioral health crisis side of things that is separate from law enforcement to support people who are going through crisis and oftentimes mistakenly taken as harmful to themselves or to the public, and in many communities ended up being handled by law enforcement. So how does it work? As of today, this is how it works when someone dials 988, depending on the area code. However, everyone calls into 988. If you dial today, you'll hear the prompt. You can press 1 to be directed to the Veteran Crisis Line, and that is handled by the Veterans Affairs folks. So that is routed out of the state. Press 2 will be connected to the Spanish language subnetwork. Spanish-speaking counselors will be speaking to people who press 2. This is kind of new. This is launched in the spring as a pilot, and now it's nationwide. Press 3 could be directed to LGBTQ youth support. And as of now, it is supported by the Trevor Project. So someone from the Trevor Project nationwide will be supporting people who chose to press 3 to have specific support. If you stay on the line and if you have a 302 area code, this will be routed to Contact Lifeline. That is a nonprofit, has been operating in the state of Delaware, based in Newcastle County for 40 years. And they're experienced part-timers and volunteers who have been trained to answer calls from people who are experiencing behavioral health crisis, suicidal crisis, as well as sexual assault. If for some reason they could not pick up, multiple people are calling in, they're occupied, or whatever reason, the call will not be dropped. If Contact Lifeline cannot answer the call right at this moment, it will be rerouted to a national backup center. So someone will always answer. This is also relatively new. There's another option. There are another 2 options of engaging with the counselors, not through phone calls, is through texting and chatting. So for texting, obviously we text to 988. And for chatting, you go to this website, 988 Lifeline, and chat. There's a free text survey, but then you'll be chatting with someone. I do this a lot with my friends and family. And so I think it's probably also a trend. It's not just for young people anymore. Texting and chatting is a way to provide support. As of today, Delaware does not have capacity for answering 988 text and chat. All the texts and chats as of today will be routed to a national backup center. And again, backup center still is staffed by trained counselors who understand how to handle a mental health crisis. So just very quickly, what is the difference? What is the difference between 988 and 911? There are 3 main differences. For 911, when you call, people know it, and almost within the first 30 seconds, the person who picked up will dispatch somebody. So it would be police, fire, or ambulance within seconds will be dispatched, depending on the type of crisis. On the other hand, most of the 988 calls will be resolved by phone, text, and chat. So that conversation is the intervention. So for 90% of the time. As a result, a typical call to 988 lasts less than a minute. You know, dispatch goes out quickly. A typical 988 call lasts about 16 minutes. It's a conversation, that's an intervention. Finally, 911 typically don't do any follow-up. Once it's resolved or disposed, will be the end of that 911 engagement. On the other hand, it's best practice that 988 will have follow-up calls if the individual is deemed high risk or elevated risk. The best practice is to follow-up call with consent within 24 to 72 hours. So how do we implement 988 in the state? I start with this because this is the most recent. We've been planning and meeting and making plans and putting resources in place to expand. However, what really infuses new energy is this 988 bill. That was signed into law by Governor Carney last week on Wednesday, along with 2 other bills, HB 3 and 4, to really, I'm not going to speak on those 2, it's related to school mental health. But what this bill does, HB 160 substitute number 2, is the following 3 things. One is it will authorize the Department of Finance to levy a 988 telecom surcharge on all the state 302 numbers, including landlines and mobile phones and prepaid numbers, at 60 cents per month as a surcharge, which is the same level as the 911 surcharge on your phone bill. The revenue of that surcharge is going to be deposited into a newly created Behavioral Health Crisis Services Intervention Fund. So that will be created. But in addition to that, the law now also creates Behavioral Health Crisis Services Intervention Board, which is chaired by the Division Director of DSAM, as well as Division Director of Children's Department's PDH, Prevention and Behavioral Health. So with the 2 chairs and a 18-member board membership, they're charged to do the assessment of the crisis continuum and presenting the dignitaries with a report every year, as well as planning for the Behavioral Health Crisis Intervention Center. I'm going so fast. And I'm good? Yep. All right, so process. So this is how the 988 planning process has unfolded since 2021. The coalition has been established in the spring of 2021, and we have met multiple times throughout that 12 months period using a planning grant, a small planning grant. And it was during COVID. So we're doing a lot of virtual meetings as we go. We submitted a plan to SAMHSA in January, which told the federal government about our background, what is our status quo, what is our infrastructure, and also how are we going to roll this out in the next year. So this is the end of sort of the planning period, and now we're launching into the actual implementation. This is only a selection of the organizations who have participated in the 988 coalition meetings. As you can see here, not only the agencies are participating as well as our federal partners, but we also have MHA Delaware, NAMI Delaware, RI, Classy, and a few other providers who are in the conversation. So through that activity, and thanks to Dr. Martin's help in trying to collate, what do we know about Delaware's crisis response continuum in terms of number of crisis calls coming in? We learned that there are 3 services that's currently operating and continue to operate in the state of Delaware when someone was going through crisis. It's a contact lifeline, which I already mentioned. The DSAM adult crisis lines. There are 2 1-800 numbers. They're part of the CIS, Crisis Intervention Services, that also dispatch mobile crisis. So DSAM's adult crisis lines, 2 1-800 numbers, one in Newcastle, the other one in Ellendale. They answer 60% of all the crisis calls coming from Delawareans. A third service that provides 1-800 numbers when behavioral health crisis happens is a child crisis line operated by Delaware Guidance Services. So overall, in 2022, based on the data, about 24,000 calls came in through these lines, and we're talking about, I don't know, 4 1-800 numbers already, plus 988. That are coming through because of behavioral health or suicidal crises. You may say, what about 911? Well, actually, we don't have that information because 911 is coding things differently. But we know it's a large number of crisis calls, possibly in a gray area of whether or not this is a behavioral health crisis coming into 911. And we're working very closely with 911 administrator in the state to really understand, because when 988 becomes much more well-known, there will be some diversion of traffic. People would know to call 988 instead of calling the police. We heard that from 911, sometimes they get calls because someone is senior and have dementia and is calling in panic that my husband is stealing my credit card. Over and over, they might get the same calls from the same person over and over. Sometimes they'll get calls of someone who is really down because of breakup, and so and of course, as you know, sometimes they do get a lot of calls for behavioral health crisis involving substance use. So we're very fortunate to have the collaboration of 911 and all the first responders. They really do believe that strengthening the behavioral health side is also a benefit to them as well, so they can focus on what they do best. A little bit of the data that in terms of the year 1 call volume since its launch about a year ago in July 2022, nationwide there's an initial spike once it's launched because it's in the media. So there was a 45% uptick But over time, the volume has increased by about 40%. We see 45% increase between June 2023 and June 2022, which is kind of mirroring the trend. And this isn't a projection that we made early on 2 years ago, based on a federal model. They projected that in a low scenario, Delaware will be getting about 5,600 calls a year, but in fact, we got about 4,900 calls in year one. So close enough, we're not seeing this quite yet. And there are reasons suspected, I cannot prove this. There are two suspected theories of why we're not seeing a projected significant increase, like 12,000 calls a year in year one. Reason number one is because we have already 3 services providing crisis intervention services. People who are struggling and their families who are struggling with mental health crisis and suicidal crisis already are connected to these services they're familiar with. So that's theory number one, hypothesis number one. Hypothesis number two, I think it's true, is because there is no public marketing. There's no marketing. There's no public awareness campaign, which we're just starting to kick off as we expand capacity. It would be amiss if I don't mention that text and chat is increasing dramatically. So at the same time, we had a small pilot with Contact Lifeline, but fielding all the text and chat using the existing call center infrastructure and people who are trained to talk to people on the phone, it has proven to be difficult. So this will be one of our priorities in the next year, is to be able to bring in capacity to field text and chat. What I'm showing on this chart here is to show that from March 2022 all the way to March 2023, we see a dramatic increase in people who are utilizing 988 text and chat. And again, all these volume, about 310 text and chat a month, were answered. They're answered. They don't go nowhere. They were answered, but they were answered by counselors outside of Delaware. All right, so I think I'm gonna skip this because I think this is my last slide actually. So we're in the beginning of this implementation. We know that we have strong infrastructure in the state of Delaware, very fortunate. At the same time, workforce shortage is front and center. It's very difficult to find people who are passionate because this is a taxing job. This is a very taxing job, 24/7, and you're meeting people at the worst moments of their lives. And we're also expecting credentials, master's level clinicians, and so it is difficult. So I think workforce challenges are being handled, but it is front and center on all the call centers' minds. However, with the new bill coming into play, bringing more sustainable resources, we're hoping that our plan of building capacity, starting with building technology platforms, so all the the call centers will have the right technology to connect, share information with each other, and really coordinate in a consistent fashion. We're far behind from 911, as you can imagine. 911 is 50 years old by this time. It doesn't happen overnight, but we're catching up. In the coming years, DSAM's crisis intervention services will go live as the 911 backup center that will bring the number of 988. Did I say 911? Sorry, as a 988 backup center. So when that happens later this year, it will bring the number of 988 centers in Delaware from 1 center to 2. So we will have 2 centers in Delaware when CIS, DSAM CIS goes live. Over time, we're working on a lot of the clinical protocols, data submissions, interagency MOUs for data sharing, all of these sexy, fun stuff as a bureaucrat. Then the KPIs, dashboard, marketing campaign, and full implementation and monitoring will come into play at a later stage. So all the numbers will continue to operate as of now until we have a mechanism to really staff it up so that all the 1-800 calls can come into the same place. This is our vision for the behavioral health crisis communication call center. But in the interim, all these numbers will continue to operate. I do want to mention that the ongoing work in terms of communications, which we can probably talk about at a different time, is ongoing and benefited from the infusion of federal dollars to do that. So you're seeing some of the promo materials and in front of you, but coming soon, there will be a public campaign that you will see more exposure to educate Delawareans about 988 and when to call. Our last marketing strategy meeting really worked away and saying, don't think too much about who to target and where to target. Let's make people know that 988 is here and call when you're in crisis. Of course, in different languages as needed, but we don't need to, because the awareness is so low. So getting people to be aware that 988 is here is the most important. So I'm going to conclude that and happy to take questions. Oh, I did not get this part at all, but I think I might have to skip and just say one word, that 988 Handoffs is only one of the 3 components that is needed for the system to support someone going through crisis. According to SAMHSA, we need to build capacity for someone to talk to, 24/7 call hubs, someone to respond, someone to come to you. For higher risk individuals, that's about 20% of the time. And we also need somewhere to go, as I mentioned earlier. So this will involve continuous effort and resources, of course, in order to expand. So the way I think about it is 988 is the start, and it's a catalyst for a really system transformation and really separate out all these support from police showing up, grabbing someone and put this person in ED. I think that has been the default, very costly. And the reason why we're doing this for behavioral crisis is to separate it out and also provide the right care, the right person at the right time. All right, so these are all the resources available, but happy to answer questions.
I look at the way things are messaged here. So the service is both for people in crisis, but it is also, say, for a family member who wants to find services for a relative.
Yes.
That being the case, I'm just wondering, just in terms of connecting with other services they might use, like something like Delaware Helpline or 211, somebody might call them to find, not to crisis, but to find service. You'd like to connect with that kind of group?
Yeah, it is possible. And 211 has been engaged with our conversation because some calls did end up there.
Right.
So there are 2 things, right? So one is they would need to know, just like a lot of other, someone called BTCS is, in the act of, with firearms and so on, you'd be like, well, hang out and call 911. Similarly, so if things need to be escalated to a different service, we're working with these partners such as 211 to know when to not try to handle and hand it over to the professional.
I just didn't see them on
The other,
they've had a lot of marketing over the years, 211.
that is true.
Yeah.
That is true. And Maryland has used 211 as a 311 as a start, but this is not a direction we're taking in the state of Delaware because we do think that a professional support is needed. But the other direction of connecting people to services, there are many doors are open for this purpose, including our warm line, the Hope line, that's peer supported warm line. That 988 could hand off people who are merely looking for information to other services as well. Not just 211, but also other services.
Question, what's your process for recruiting and hiring the intake specialists, and what type of training would they receive?
I'm going to try to answer that question. I think the training credential part is slightly more involved than I can answer. So there are contact lifelines recruiting through volunteers, part-timers. So that is a different process. the state of Delaware Crisis Intervention Services, the recruitment is through the usual merit Delaware state employee recruitment process. So there are currently multiple positions open. The credentials, it's a moving target because as of now, it's the MSW level of training, social worker training, some political training. You probably know more than I do. But that, and I think there are also positions open for peer specialists that has a different credential and licensing requirement. I can circle back with you if you're interested in a particular position.
I know that the state is doing the second round of training for mental health first aiders. That's provided by the National Mental Health Council. And they've also done the youth mental health first aiders. And I think with that evidence-based curriculum and the training that's required, could be helpful too. Especially if young people, so young people can call this too, the 988, if they're in crisis.
Hi, thank you for all this. This has been a really helpful overview for me. The 988 texting, you said that's currently going somewhere else. I'm curious, is that going to crisis text line by any chance?
It is not.
Okay. Is there a plan, given the volume of calls that are coming in or texting? Is there a plan to do that in-house eventually? And apologies if I missed you saying that.
There is a plan to answer text and chat in state. The details about in-house
Well,
is
I meant in
like,
that's what I meant.
yeah. So that could most likely in the short term will through contracting. And that's why I can't say too much about, what the contracting situation might look like. But as you said, right now they're going into the national text line and there are multiple backup centers nationwide, a network of backup centers to answer text line, to answer text. And I think Crisis Text Line is one of those vendors for the federal government.
And any sense of like when we might see this start happening in Delaware?
I'm hoping in the next few months that contracting could happen. So, but contract.
That's a lot quicker than I expected, so.
Yeah, and we complain about procurement and contracting a lot, but without them, we cannot do what we do.
So we're gonna switch gears to police diversion. Were there any other questions for Dr. No? All right. Thank you.
Okay, police diversion program. So just to start, right now we're just working with the state police, but we do have the capacity to expand to other police agencies. But right now, this is just a state police program. So it would I wanted to explain before I start with the PowerPoint. So we have professionals, behavioral health professionals at each state police location, master's level clinicians and also peers, and I supervise all those professionals statewide. So anyway, to start, the police diversion program was a collaborative endeavor between 3 state agencies, DSAM, the state police, and DOJ. The program's goals are to provide immediate help for people in mental health crisis. As mentioned, Dr. Wong's presentation, the police for mental health crisis, it really presents a challenge for the police. So we're there to help with any type of mental health crisis, along with calling crisis intervention if they need to be involved at the same time. The second one is to provide access to recovery services for those that have substance abuse issues. And these include overdoses or any other types of drug-related criminal activity. You know, and this could be at the present, you know, we can be called to the scene of an overdose, or someone presents to the police. We only work 8 to 4:30 Monday through Friday, so on a weekend, so we could get a referral on Monday morning that happened sometime over the weekend. So there's different ways the police communicate that they want help for certain types of, for these types of problems. The third is provide arrest diversion, and I wanted to explain what arrest diversion is. Someone's arrested for, we only help in this type of endeavor with low-level crimes like shoplifting, simple possession, loitering, things like that. So if a person, instead of getting a shoplifting charge, they're offered the opportunity to go through a diversion program, they would be with us for 6 months. We would send them to treatment and do follow-up care. So we've have had the fewest in this type of category, but it still is an option for the people we serve. There is a fourth option that has come up that happens, like I said, the police just refer misdemeanors. Well, there are people that have felonies that the police also will refer to us. Someone, say like a nurse who was taking illegal opiates from, you know, the place where they were working, that's actually a felony. So they come to us and see, you know, sometimes, you know, ask for help. How can we help this person? So there's something called drug diversion court. So we would help them get into drug diversion court and from there. So the leadership team began initially as a recommendation from the Lieutenant Governor. And then Major Sean Moriarty from the Delaware State Police assembled the members of the team from DSAM and the Department of Justice and made subsequent plans. I actually came on board in 2020, so I wasn't involved in the initial planning. The philosophy and goals, basically, the police are very busy and they want help with behavioral health situations, and they really want this help. We've run into some opposition, but for the most part, they really want our help, and they really accept it willingly, and if anything, they want more of our help. The goals is to reduce opiate deaths by intervention and treatment, reduce crime, provide opportunity and accountability for those with substance use disorders, immediate treatment. We provide immediate treatment. So we, like I mentioned, we can go out to the scene, or people are brought back in lockup, and we can start the process and get that treatment immediately. I've had people in lockup that the treatment provider has actually picked up from lockup, taken the inpatient treatment from lockup, and the police are all on board with us. And then, as Dr. Nuno Martins will talk about in a minute, we provide follow-up tracking And we also provide the extra tools for police to resolve issues with behavioral health component. There are 3 initial entry pathways: overdose response, people that overdose, co-occurring mental health and substance abuse use disorders, and pre-arrest diversion. And how it usually works, a trooper comes across someone that they think has a behavioral health need, and they ask the person if they're willing to accept help. And then the trooper can either call us, email us, bring them back to the police station. There's several ways that they can get us involved. It's a holistic approach. And so we don't just help with treatment. If the person is homeless, we help with homelessness. If they're in need of a job or anything else, we can help in those areas too. Our main goal is to help people get into treatment and provide treatment recommendations. But we can help in any type of area of need. So this is what I really wanted to focus on. Like I mentioned before, we have staff embedded at every state police location throughout the state. And we're available Monday through Friday, 8 to 4:30 is our time, but we've had staff work up to 8, 9 o'clock at night, you know, depending on the situation and things like that. A warm handoff, this is, we've had the most success with warm handoffs. This is when the police actually get us contact with the person immediately. And like I said, it could be being called to the scene. It could be the person is in lockup, things of that nature. Like I mentioned before, we provide referrals to other services as needed. And it's a whole range of things. Even person said, a lot of times we come across a person that says, I'm not ready for treatment now, but I'm willing for us to stay in contact with them. And so we stay in contact with them. We've had people that we followed for over a year, and then they call us and say, I'm ready for treatment now, and we get them into treatment. So we don't just, it's not just a one-time thing of the police have contact, we ask if they want help, and then, you know, so we fought the people. It is a voluntary program, so if they say they don't want our help, then we don't usually follow up, but there are certain situations that we do follow up with. Overdose referrals are one that even if they decline, we'll still follow up from time to time to see how they're doing. And this is how care manager, this is how, things work with the police and the care manager. This is one of our peers at Troop 7 in Georgetown, working with the police. And I believe we have pictures of some of our staff at each police location. As I mentioned before, it's a 2-person care team at each troop location. And lastly, last couple things I'd like to talk about is that each state troop location is very, very different. There's a place, Odessa has Troop 9. It's in an historic building, and they won't let any upgrades, anything. So it still has like 1950 lie detector tests and things like that. So, and deadbolt locks instead of electronic locks and things like that. So everything is very different. But lastly, though, what I wanted to talk about is when we do get the emails and the when we don't get real-time referrals, we do get addresses and phone numbers, and we go out to the person's, where they're living. So we get to see how a lot of these people live and what their needs really are. And it's really has really opened eyes to how we do business. And also in that initial, a lot of times you would think people would say, they would have reservations. Most of the time, they're happy to see somebody that they know they can reach out for help. So that's been my experience in this program. So I'll turn it over to Dr. Martins.
Here. Hi, good morning, everyone. My name is Dr. Martins. I'm the chief of the Planning Analytics Unit, which is one of the 3 units of the Research Evaluation Population Health Bureau, which is responsible for conducting the evaluation work for the PDP program. So today, during my presentation, I will be providing an overview of the evaluation plan that was designed for PDP. I will be discussing the performance measures that we developed, and I will be presenting our first results of our evaluation work. So before I start focusing on the numbers, I would like to introduce our team. In this picture from the left to the right, you can see Shalice Newell and Harti Bahal. They are analysts in my team. They are responsible for data management and analysis. Then we have Chris Frazier, which is the former chief of research evaluation, and Dr. Wong. They were responsible for the initial design of the evaluation plan that was revised more recently by our team. And then you can see myself in the picture as well. So the evaluation plan that we developed, it's aimed to answer 3 questions. So question number 1, how many people does PDP reach? So we have 2 performance measures in order to answer this question. The first one is the referral volume, while the second one is the contact rate. So we want to understand how many referrals we are receiving, and of those referrals that we receive, how many individuals are we able to make contact with? First, I was almost saying research question number 2. It's because of my academic background. I'm sorry. So evaluation question number 2, how well does PDP work? So in order to address this question, we are looking at acceptance rate and service connection. So of the individuals that we are able to make contact with, what is the percentage that is accepting the program? And of those that accept the program, how many of them are having access to services? How many of them are being connected to treatment? And how many of them are having access to housing assistance, food assistance, or other type of community resources? Third question that we want to answer with our evaluation plan, does the PDP program make a difference? And in order to answer this question, we need to look at treatment completion rate, overdose reduction rates, and also recidivism rate. So these are the 3 measures. For the purpose of today's presentation, I will be focusing on the first 2 questions, because regarding the third question, we are just starting to gather this data. So focusing on how many people does PDP reach, the program was originally launched in the spring of 2021, and the program was launched in 3 troop locations, Troop 2, 3, and 7. And in total, since the start of the program, we already received 3,324 referrals. But here in 2021, so the red line, you can see that we were averaging around 55, 60 referrals a month. But in March of 2022, 5 additional troops were added to the program, troops 1, 4, 5, 6, and 9. And as a result, the number of referrals that we receive each month, it continued to increase. And as you can see, starting March 2022, we are averaging many more referrals that we were averaging in the year before. And when we look at 2023 data, starting in March, we are having some of the highest number of referrals since the start of the program. So in fact, in April, May, June, July, we had 3 of the months with the highest number of referrals since the start of the program. So the program is still growing, expanding. People are becoming more familiar with PDP, and as a result, we are seeing an increase in the number of referrals that we receive from the Delaware State Troop. So what type of referrals are we receiving? So of the 3,324 referral, the large majority, so almost 73%, they are co-occurring mental health SUD referrals. 20.5% are overdose response referrals. So these are incidents in which individuals are consuming drugs or had a non-fatal overdose. They are referred to us, and our team connects with these individuals. 5.1% of the referrals, they are mental health referrals. These are strict mental health referrals. These are individuals that have mental health conditions. They are referred to us through the Delaware State Police, and we engage with them. Then we have 1.4 is the category other. So these are referrals that will not fall under the other categories that we have. And 0.2% of the referrals, they are pre-arrest diversion referrals. Focusing now on the demographics of the referrals that we receive, starting with age. Of the 3,223 referrals, 28.9% of the individuals are in the age group of 26 to 35 years old, while 26.8 are in the 36 to 45 years old. So in general, approximately 55% of the referrals that we receive, these individuals are between 26 and 45 years old. Then 15.3 are in the age group of 46 to 55, and around 10% are in the categories of 18 to 25 and 56 to 65 years old. Regarding gender, 58.7 of the referrals, these individuals are male, while 41.3, they are female. Finally, regarding race and ethnicity, 62% of the referrals received, these individuals were white, 21.4, they are Black, African American, 2% are Hispanic, Latino, 0.3 are Asian, and 0.1 are Native Hawaiian. And we don't know the race category of approximately 14% of the referrals that we receive. So looking now at our contact rate, which is one of the performance measures in order to look at how many people are we reaching and connecting with. So since the start of the program until July 2023, we were able to make contact with 55% of the referrals that we received. So we made contact with 1,825 individuals. I would like to stress that it can be challenging to make contact with these individuals, and Tom can talk more about that. And why is it challenging? In first place, we are talking of many individuals that they can be a transient population. Many of them are homeless, so it's difficult to make contact with them. And the second reason is that in the police reports that we receive, sometimes there's no address, or there's no information about the phone number. So it is challenging to make contact with these individuals. But as a result of the evaluation work that we have been conducting, we realized that we were able to make contact with 45 to 50% of the referrals that we received. So we start thinking about strategies that could be adopted in order to improve this rate. So the first strategy was to have troopers providing having cards with information about the care managers at the different troops that are being delivered to these individuals so that they can make contact directly with our teams. So this was the first strategy. The second one was to reduce the amount of time between the incident and our teams receiving the referrals. And as a result, when we look at the data, referral data from 2023 only, so referrals received between January and July 2023, of the 1,205 referrals, we made contact with 804 individuals. So this gives us a contact rate of almost 67%. So we are seeing an improvement in our contact rates over the past months. So focusing now on the second question, how well does PDP work? I will start with our acceptance rate. So our teams were able, of the total referrals that we received, our teams were able to make contact with 1,825 individuals. So of these individuals, 675 accepted the program. So this gives us an acceptance rate of 37%. Then we have 41.4% of the individuals that we connected that declined the program. And the main reason why people declined the program, so 26.1%, they declined the program because they were already receiving treatment. So as a result of that, they didn't feel the need to accept the program. The second reason is 8.5% of the individuals indicated that they are interested, but they are not ready to accept the program. But what we are seeing in the program, and once again, Tom can talk more about this, is that sometimes people, they don't accept the program immediately, but some weeks later or months later, they will connect with the team and say, okay, now I'm ready to accept treatment. I need some housing resources. I need help filling a job application, and they will connect with the program and they will work with the care managers we have at the different troop locations. And something that I think it's important to stress is that PDP is not only about referring people to treatment. It's also about building relationships with these individuals, letting them know that the program exists, that we have resources that they can use, that we are here to help, and that there's people that care about them. So that's why it's important to look at acceptance rates, percentage of individuals that are referred to treatment, but it is also about building relationships with these individuals. Regarding the individuals who declined the program, 44% did not provide a reason why they declined the program. And then, of the total number of individuals that we were able to make contact with, 21.6, they still haven't decided if they want to accept the program or not. These are also individuals that might make contact with us at a later time. Regarding service connection, which is our second performance measure. So of the 675 individuals that accepted the program, 65%, they have been admitted to treatment. And what types of treatment? What are the treatment settings? So 45.2, they were admitted to inpatient treatment, 23.1 to outpatient treatment. Then almost more than a quarter of them, they were admitted to treatment, but they also received resources through the PDP program. These resources can be very different. Sometimes it's food assisting, other times housing assistance. They can be community resources as well. So refer them to a food bank or help them with searching for a job, etc. And 6.4% of the individuals admitted to treatment, they receive MAT. Then we have individuals that they accepted the program, but they were not admitted to treatment. We are talking about 30% of the individuals that were not admitted to treatment. So they were not admitted to treatment, but they received some kind of resources through the program. So 46.3 received community resources. I already provided some examples of what some of these resources are. 35.1 had a motivational interview with our care managers. 5.9 received housing assistance, and 5.9 received food assistance. So very briefly, going back to, does the program make a difference? Here we have the three performance measures that we are currently collecting data. The first one is the treatment completion rate. We know where are these individuals being referred. We know admission dates, and we have our internal databases that we can check if they completed treatment or not and when. So this is information that we are currently gathering and that we will be reporting in the months ahead. Then we have the second measure, which is overdose reduction, in which we will be comparing incidences of fatal and non-fatal overdose rates. And finally, we will be looking at recidivism to compare rearrest rates. So this is, I say future work, but it's work that we are starting to conduct now. So hopefully in the upcoming months, we will be able to report this information. I believe this concludes our presentation. Tom and I, we are available to answer your questions.
When you break it down by people who go into treatment, do you have a distinction between the substance use treatment versus psychiatric treatment?
Yes, we can have, so for each case that we manage, we can keep track of the treatment setting in which they are, yes.
Okay, so that would be the number you provided is both psychiatric as well as substance disorder treatment.
For treatment,
Yeah,
And do you have any data on like diversion from emergency departments for people who have like very serious mental illness or stuff?
these are referrals coming only from the Delaware State Police.
Yeah, I just didn't know if they're dropping people off at the hospital or, because that's one of the goals is to divert from emergency departments if there's any tracking mechanisms.
If the state police does not decide to divert and refer to DSAM, it's not part of this program.
That's good.
Right. And so the police want to resolve the issue as soon as possible. So they're still mostly gonna, if they can take someone to the emergency room, especially after hours, if our staff is there, they're gonna do that. But we follow up after the fact.
Okay.
And so they let us know where they dropped the person off and we follow up and go to that person wherever they are.
Yeah, I just had a question, what you were doing as follow-up mechanisms for people that, so they weren't interested, but maybe interested in the future, like what does the follow-up process look like for that?
So, it's very individualized, number one, but, at the least, we follow up once a month.
Okay.
But we have people that say, I have court coming up in a month, I'll let you know, after my court situation, what I want to do.
And that is peers that follow up, or is it an officer that follows up?
Well, it depends. So the way we try to work is a partnership with each other. And this is part of my supervision. We have peers that are very, very capable of making clinical decisions. And so it depends. If the peer has the best relationship with the person, then they would probably contact the person from time to time to see how they're doing. So that's usually how it works.
Thank you.
Other questions?
I didn't hear, what is the monitoring period for some of those efforts, like with recidivism and overdoses? 6 months, 1 year? What is it?
So according to our evaluation plan, it will be 3, 6, 9 months.
Good question. I just also was curious if there's any data on like pending placement, like people who can't find a placement. Because I know that's something particularly psychiatric. Is that something to track? If they say they do accept treatment or they're open to treatment, but they can't find a placement, is that? Or is it they're getting some service?
We usually get them in, if they want treatment, we'll find a way to get them in the treatment.
And the vast majority of the program, well, the program was established, at least from the start, for SED clients. So the mental health only psychiatric clients are only relatively recent.
Yeah.
Right, but, so we actually refer, there's a lot of places out of state in Maryland, Pennsylvania, that also will accept Delaware Medicaid. So we've referred people to New Jersey, so we have a wide range of different places we refer people to, including mental health options too, but mental health options can be a little bit strict, more strict, but we'll try and find something somewhere for the client.
I don't recollect of any data of people that we were not able to refer to a provider, yeah.
If you have to, if the officer transports them to the emergency room, how long can they stay there before they're seen? And, I believe you said you guys operate Monday through Friday, 8 to 4, and this happens on the weekend. And the emergency room says within 24 hours, we couldn't find someone to come in, appear to come in and talk to them, and they release them. Is that part of the recidivism, or is there?
It could
How do
be,
you connect them?
it could be, but, so our staff would get that information Monday morning and we would reach out to that person as soon as possible. The police officer would leave us the address, where the person lives. But, it's a work in progress. Like I said, our most success is when we're getting those warm handoffs. When we don't get the warm handoffs, people will give wrong addresses, wrong phone numbers to the police. The police really don't verify whether they're the right address, phone number. So a lot of times that actually happens more than we want it to happen, that a person will go to the hospital over the weekend, or whatever, and then we can't find them. That's part of our, contact. But as you saw, our contact percentage is going up. So one of the strategies that Dr. Martins did talk about, our staff has decided through a lot of information that instead of calling someone, we'll go directly to that person's house or where they're living and talk to them in person. A lot of times with phone calls, people are more easy to say, no, I don't want help. So that's one of the strategies we've implemented to get those contact personnel.
Other questions? Any thoughts? Yes, David.
So I'm very curious about some of the plans for the outcome data stuff and the linking data stuff, which stop me if I'm gonna get in the weeds, feel free. But is the plan to do like comparison groups or just kind of look at the data for those clients? And because I feel like there's a billion things that you can do, and then my brain starts going on the billion things, and I'm like, which of these things are actually reasonable? You know what I mean?
So that's a good question, and let me go back. Okay, this is a good one. So when we talk about, for instance, treatment completion rate, we are only looking at individuals that have been admitted to treatment. That's what will be our focus. But when we look at overdose reaction, we'll be comparing the individuals who accepted the program versus the one who did not accept the program, because we can have access to through the behavioral health data that we manage, that is overdose data, fatal and some non-fatal. We will be able to compare these two different groups. So, so the ones who accepted versus the ones who did not accept it, to see if we see difference in the rates in terms of fatal and non-fatal overdoses. Regarding recidivism, I think, if I'm not wrong, according to evaluation plan, we will also be looking at the individuals who accepted versus the ones who did not accept the program. So these are, it depends, it varies from performance measure to performance measure. But in the case of the last two, we will be looking at who accepted versus who did not accept the program.
Okay, well, with the recidivism, I think it will probably be interesting to see like what people are getting arrested for too, between those groups.
Yeah, that, yes.
That might be another thing where we're getting to.
And also that depends on, we are not, to look at this, so while the treatment rate and the overdose reduction rate, we have access to the data. In the case of recidivism, we rely on data from Delges. So it's a little bit more challenging, and we need to be a little bit more conservative in the approach and the amount of data that we can have access to and that we can request. So that's the difference.
Just a follow up, and thank you for this presentation. Where's your overdose data coming from again?
The overdose data, so that's a very good question. So fatal overdose data, every time there is a suspected overdose death in the state, DCM receives an alert from the Division of Forensic Science. So, and that alert contains information about the individual, the circumstances of the incident, and demographics. So this is suspected overdose data, hasn't been confirmed by toxicology reports, but based on historical data, patterns and trends found are very similar to the ones of the confirmed overdose deaths data. So that's how we have access to overdose data, fatal overdose data. It's through the DIAs, death investigation alerts that are sent from the Division of Forensic Science to DHSS. Regarding the non-fatal overdose data right now, and probably Claire can talk a little bit more about that, we only have access to some of that data through a program that we have at DSM called the LIST program that aims to direct people to treatments that are involved in mental health incidents. So through that program, we are able to receive some of the non-fatal overdose data. We also receive non-fatal overdose data through the PDP program, but it only represents probably 20%, 15 to 20% of the non-fatal overdoses that happen in the state. All the remaining data would be EMS data that currently we don't have access. We are working to have access to that data through one of the initiatives from DSM, but currently we don't have access to that data. But we have access to fatal overdose data, even though if it is the suspected overdose death data. Yeah.
Other questions? What is that? I just want to make a comment that it's really exciting to hear that police officers are interested and that there's a response to that. And I just want to thank you guys.
Right. And my experience with police officers has been very positive, and it's just been, I think, a tremendous boost to the community in general. Also, they kind of see us working together, and just really, helps everyone feelings about it.
What I think is really exciting is a couple of years ago, DSM was talking about the hub model, right? And what I think is exciting is seeing that kind of evolve, and that there really is no wrong door. That DSM is really leaning into a space of getting people connected to care, whatever door that is, whether it's through police interaction or 988 or peers or whatever the case may be. So I think that's really exciting stuff. And I want to thank our presenters today for some great information. We're gonna now, if you have things that are